project will focus on the richer social pediatrics model. What does richer stand for? Richer stands for Responsive, Intersectional, Interdisciplinary Child Community Health, Education, and Research. And it is an initiative that was developed by the BC Children's Hospital in 2007. It was designed to meet the needs of children, youth, and families living in Vancouver's inner city neighborhoods, equivalent to Regent Park area in Toronto. Families and children living in this section of Vancouver were seen as having high rates of developmental delays and poor health. These disadvantages are the manifestations of health inequities, and such results in barriers to accessing primary health care. Next, we'll be looking at context and indicators. Richer was designed in the intent to provide timely access to healthcare across the spectrum of primary to specialized services for a community of children who have been marginalized due to social and material circumstances and who shoulder the disproportionate burden of diseases that effectively demonstrates inequities in health throughout their life course. The Richer initiative focused on creating and fostering access to primary health care for children and families facing significant poverty and multiple forms of social and material vulnerability. The demographics that the Richer initiative looked at were children and families from the inner cities of Vancouver who are at a disadvantage due to poverty, race, and gender. Particularly children under such negative circumstances are at a greater risk for long-term disadvantages regarding their health and healthcare quality. Groups specified are families with substance abuse or mental health history, new immigrant families, lone parents, First Nations. One of the key main goals of this initiative was to provide timely access of healthcare, including primary and specialized care for children and families who are vulnerable due to their social and physical inequalities. To facilitate and integrate healthcare services from primary to tertiary, adapting to the needs of children, youth, and family living in the inner Vancouver region. This includes creating a relationship with the community and building relationships. Listen to what the community has to say and also listen to what the community needs. Creating and fostering better access. Diminishing and reducing inequalities. Special attention is paid to routine developmental surveillance of children, case management and coordination of care with other providers, preliminary detailed assessment of children, direct linkage with specialized healthcare services. This section involves stakeholders. Patients are one of the stakeholders. This involves children, youth, and families living in the inner cities of Vancouver who suffer the social and material deprivation. Specifically, this includes areas of Grandview Woodlands, Strathcona, and downtown Eastside. Service providers include social pediatrics, primary health providers, mental health service providers, and secondary and tertiary service providers. Funders include the Canadian Institute of Health Research, Canadian Nurse Association, and the British Columbia Medical Service Foundation. These are the funders. Health authorities include Canadian Institute of Health Research and Vancouver Coastal Health Authority. These are the health authorities. Community partners include NEFCO, RACAM, Child Health BC, Vancouver Native Health, and Alive. These are the community partners who are involved in funding the initiative and the results produced by the initiative. Researchers are involved in producing the results of the initiative and changes that they believe can be made to improve results. They conduct research to gather data on social and structural obstacles faced by the vulnerable families when trying to access health care, barriers faced by the clinicians distributing the healthcare services, and ways to connect with the community and create friendly environments. The next section will focus on analysis and evaluation. There are specific groups that are more likely to experience poverty in Canada, and children cover a major part of this group. Since poverty is a strong predictor of life expectancy, the neighborhood you live in can greatly affect one's health. Richer was developed to allow collaboration between a tertiary care facility, primary care facility, public health, and community organizations. Richer serves children and families that the literature identifies as vulnerable, those from households that have one or more many of the following disadvantages: low income, lone parent, or a new immigrant household. Richer serves children with developmental delays. Survey results indicate that children have physical, language, and emotional challenges will face future health outcomes. Richer overcomes access barriers, both by providing timely, mostly on the same day, place-based access, but most notably through the clinician's interpersonal style that is compassionate and respectful, knows the family and their situation, involves the parents in decision-making, empowers families towards better health outcomes, and brings resources closer. Some of the main challenges the Richer Initiative faces are most of the healthcare services and the community in the socially and economically deprived communities are more focused on the adult population, so the children are often ignored or do not receive the proper care they need. The community organization that will benefit from the initiative are not able to gain it because they are already overburdened. It takes time to gain the trust of the community. It takes a long time for the community members to have trust. Some of the many central issues and problems the Richer Initiative receives are: health services are usually organized into programs by medical specialty, age group, or geographical region, which can lead to fragmented policies and practices, such as complex and confusing points of entry. An assumption that families will have the knowledge, skills, and resources to navigate the healthcare system, to follow through on referrals, and to clearly present their child's concerns to the healthcare provider. Complexity of access due to families' social circumstances and clinicians' response to them. Thus, to combat these issues and barriers, Richer has created new structural arrangements to facilitate access and to mobilize a range of resources needed to help support families with their child's health condition. Implementing different models of PHC. PHC stands for Primary Health Care, to ensure access to the full range of health services and care that is responsive. Creating clinical programs that are linked with services across the continuum of care, from access to community-based networks and specialized healthcare services. And finally, clinicians becoming more mindful of the ways social context influences families' experiences. Therefore, there is a need for primary health care to be integrated with specialized services. This can be done by creating new structural arrangements to facilitate access and to mobilize the range of resources needed to support families in fostering development and managing their child's health condition. This creates a strong primary health care model that in the end leads to positive population outcomes such as increased knowledge about healthcare and reduced duration of effects of acute and episodic conditions. The concepts discussed in class relate to the central issues and problems of this initiative because the role of primary care is really important to the success of Richer. The goal of primary care is to create a greater integration and accessibility of healthcare services by clinicians to better meet the health and healthcare needs of people, especially those who are vulnerable due to multiple intersecting social determinants of health. Current achievements of Richer. By implementing the Richer initiatives, clinicians begin to understand and recognize the social roots of inequities and how it relates to how resources are mobilized to respond to the many health challenges of vulnerable children and families. This initiative has effectively allowed for health service deliveries to provide care in new, innovative, accessible, and responsive to the needs of the population. And for these parents, having someone who cares about them and who is knowledgeable and compassionate to their child and family situation is a very important aspect to this initiative. Thus, the Richer approach does foster access to primary health care for children and families facing significant poverty and multiple forms of social, food, and material vulnerability. Finally, this graph sums up everything we have talked about today. The Richer Initiative has done so much to help at-risk youth, and I hope that through this presentation, you have learned what Richer is. Thank you for listening.